This is Vermont Edition. I'm Michaela Lafrac. Today, our weather gods have bestowed on us a relatively warm spring day, perfect for gardening. If you have a green thumb, we have an upcoming free event that might be of interest. Thursday, May 15th, is Vermont Edition's annual Spring Gardening Show with Charlie Nardozzi. This year, we'll be hosting the show in front of a live studio audience at Vermont Public's Colchester Studios. Audience members will be able to submit their gardening questions for Charlie, and afterwards, we'll do a seed swap. Tickets are free, but you do need to reserve them in advance. So if you want to come, head to vermontpublic.org/events and reserve your ticket today. Now, on to today's show. If you are a regular listener, you might have heard a handful of shows that we've done over the past few months exploring the challenges facing Vermont's fragile healthcare system. Today, we're going to slice off one piece of that pie, primary care. Nearly a third of Americans don't have access to a primary care provider, according to the National Association of Community Health Centers. Later in the show, I'll sit down with the head of the Community Health Centers of Burlington to try to parse out why primary care is harder to access. It's getting harder to access than it already is. And you will also have the chance to call in. But first, we have a special audio documentary on this very subject to share with you today. Dr. Bob Primo is a primary care doctor in Island Pond in the Northeast Kingdom. He's been taking care of his community there for more than 30 years. We're going to join him for the day as he sees patients and reflects on his career. Dr. Primo worked closely with the freelance radio producer Anna Van Dyne to craft this story. Let's listen.
Okay, so I have a patient starting right now. The nurses are just putting her in. Next guy, just kind of routine, diabetes, anxiety. Next one, interestingly, I have two patients with the same name, and I think this is the one who's a nurse who's got high blood pressure. We'll see.
I'm Dr. Bob Primo. This is my list of patients for the day. I'm the primary care physician in a small town in the most rural part of Vermont. I'm one of the only primary care providers and the only MD for miles around. And I treat people of all ages, from all different walks of life, with all different kinds of problems.
Next guy is 83-year-old, tough as nails, old farmer, still helping his son on a farm. Next one's a middle-aged woman with diabetes who struggles to control her weight. I'm hoping to get a house call in to a woman that's sort of semi-palliative with heart failure.
I've been working here for 34 years, and I've gotten to know most of my patients well. Lately, though, my job has been changing, and not for the better. I waste more and more time on the computer that I could be spending with my patients, and I'm getting ready to leave. Before I do, I'd be happy to let you tag along with me for a day at the clinic as I see my patients to give you a window into what I do here.
He's big.
He's pretty good size for 4 months, isn't he?
He's the biggest boy of them all by far.
Yeah.
Not weight at birth, but weight right now. Like looking at the baby books and stuff,
Right.
what he weighs is a lot
Yeah,
more
he's
than
going
what.
to catch up to some of the other guys before they know it. They better be good. Okay.
On a given day, I often see a patient or two at the hospital. Then at the clinic, I'll usually see about 15 patients, maybe a dozen adults and 3 kids.
Yeah, 80th percentile on his height. He's 60th on his weight, so he's big, but he's not huge. Good, healthy size. Let me get the numbers down for you. So that means his Tylenol dose is to the halfway mark, the 2.5
Okay.
now.
Yeah, I've been sticking with what you told me for now while he's been teasing.
Island Pond is in the region of Vermont known as the Northeast Kingdom, which has the Canadian border to the north and New Hampshire to the east. Most things that people think of that make Vermont unique compared to the rest of the country are amplified in the Northeast Kingdom. The winter and the terrain and their isolating effects.
There's huge socioeconomic disparities in this area. You know, we're one of the poorest in the country, let alone the state.
Bobby Jo Letourneau is our community health worker. She helps patients navigate different aspects of the healthcare system and often other parts of their lives as well.
You know, we have a lot of people that are probably on assistance just because the jobs are few and far between. They don't always necessarily pay as good as other places because we are so rural. We're not a city.
Island Pond is in the center of Essex County, which has less than one person per square mile. The Island Pond Health Center, where we work, is embedded solidly in the middle of a town of about 1,000 people. It's relatively isolated. We're about 25 miles from the nearest hospital and other available medical care.
So, you know, you're locked into an area where you have very limited options.
The Island Pond Health Center has 7 exam rooms, half a dozen nurses, and an in-house pharmacy. We share the building with a dental office, so it's pretty much a one-stop shop. We have roughly 2,000 patients total, split between myself, a nurse practitioner, and a physician's assistant. I'm certified in both internal medicine and pediatrics, which means I'm able to treat pretty much anyone who walks in the door.
Dr. Primo has been a provider around here since I was a little girl. And just to be able to have that access to somebody with his knowledge base and experience, it's a big deal. I mean, he literally sees from the day you're born until the day you die and everything in between. We're never going to see that again. We're never going to be able to replace that in one person in this building the way he does it.
It's definitely swollen.
Mm.
You can see that, huh? Like through there compared to the other side.
Yeah, it's tender in this
That hurts
area.
you there too? Yeah.
Yep, it
Okay.
is tender there. You know.
So what about on the side there?
Yeah.
That's very tender. Okay. Right now, the fastest good knee people, you know, fastest, closest, is probably the Alpine Clinic in Littleton. Dr. Korsch, people like him a lot in St. J, but he's like 5 months backed up. Our knee guy in Newport recently left.
Oh,
and
geez.
Dartmouth has a pretty good wait.
Our clinic is part of Northern Counties Healthcare, which runs a handful of federally qualified health and dental centers in the region. They operate on a sliding scale that goes deeper than the state's Medicaid rules, so it provides some pretty vital services to a lot of people who need them. The organization was started by David Reynolds, who's now one of my patients.
Back when I started the health centers, the community was without any health services at all. I mean, they had solo practicing general practitioners, and then when they retired or moved away, there was nobody there. So the need for local health services was obvious.
The clinic opened in 1977. I started working here in 1991. Despite everything there is to be said about poverty and limited jobs, I found myself surrounded by a really high number of skilled, surprising, eclectic people, both those born and raised in Vermont and transplants. The community was warm and welcoming, and it was obvious from the beginning that there was limited separation between the office staff and everyone else in town.
You're part of the community, you know, and you can see very tangibly the difference you make. Whereas if you're in a hospital practice where people may just come in, you don't really know them that well maybe, and you know, they come in and they go out, and they may come and see you again or they may not. But it's the name, I think, says it well, a community health center.
My memories of the early years have gotten fuzzy, but I remember how much I loved the fact that we had a facility in the boonies that could do major medical work. I loved that I could make house calls. I loved that I could sometimes go for a swim or a run at lunchtime.
It doesn't appeal to everybody, but for those that it does, like Dr. Primo, he's fit here like, you know, a hand in a glove.
So when is opening day?
Open day efficiencies on a Saturday.
That's what I thought.
Oh, it is?
Yeah.
Yeah, coming right up. Okay.
For trout. Now, of course, you could fish now for perch and other stuff, and catch and release.
No chest pain, chest heaviness.
No.
Breathing's okay.
Yeah, up and down stairs, no problem. You know.
Just seen that thing on your arm. Is that new?
You're supposed to take that one off today. That's why we're here.
Let's get moving. We're gonna go to the other room. Okay.
Oh, okay.
Being a doctor in a place like this isn't like being a doctor in the suburbs. Because of its unusual degree of remoteness, we provide a range of care that's a lot wider than that of the average primary care clinic.
So t-shirt off and then get yourself comfortable there.
Yeah. You want me to take off my sneakers or?
No, it's fine.
Okay.
Nowadays, most of the doctor's offices around, you go in 15 minutes and whoosh, you're out the door.
Janet Osborne was the nurse manager at Island Pond Health Center for 38 years before she retired in 2015. She is perhaps the most dominant force that shaped the clinic.
When you go to the other places, you basically have to go somewhere else, whatever they're ordering. Like if Dr. Primo orders a blood test, the nurse comes in, draws the blood. If you need some medicine, if you don't have a special coverage for it and we can do it, you can fill your medicine. If you need a cardiogram, we can do your cardiogram.
I love this aspect of my job. If I was in a typical suburban outpatient practice, I would blow my brains out. Primary care docs like me are supposed to take care of hypertension and diabetes, but as soon as someone says the word heart, they're supposed to walk down the hall and see a specialist.
So when can you get this wet?
You said 48 hours.
Right. When do the stitches come out?
You said a week.
A week.
Yeah.
You can do it yourself at home. It's just like take the hem out of pants, or you can walk in here. Either one. Okay.
We'll do it.
All right.
That's no problem.
On the one hand, limited access to specialty care can be harmful to patients with significant health issues, and we sometimes have to do a lot of legwork to get patients the appointments that they need. On the other hand, patients benefit when their doctor plays a more active role in managing their complex illnesses than is commonly seen in many practices. I also do inpatient work, meaning that when my patients are in the hospital, I go in to see them. What does it mean to say you're someone's doctor if you're not there when they're at their sickest?
I think it helps greatly in their care. You know, there were kids when I started, well, young folks that would bring their babies in for their immunizations. And then before I got done, these were people bringing in their kids. So we went through several generations of the same people coming back, but they were the older ones and then they had their kids. So it gave you that much more knowledge about the family and everybody because you had been seeing them for so many years.
I've known some of my patients for so long that it can feel like seeing an old friend when they come into the clinic. Sometimes they really are old friends. After working together almost 25 years, Janet is also one of my patients now.
The place wouldn't have been the same all those years without him there. And to keep somebody that long, nowadays, they just move. I'm on the credentialing committee for the hospital, and we're constantly looking at new applications because people come and go.
Let's see. I went to bed last night and my toes were cold.
Yeah.
And it seemed like I couldn't even get them warm in bed. But when I woke up this morning, they were warm. But then this was hurting.
You don't feel sick,
No.
and you've been able to eat today.
Yes? Yeah.
Have you felt more short of breath today at all?
No.
I think this is probably irritation of one of the veins that's just under the skin.
Oh.
And the good thing is that they're not dangerous. But I always check too to make sure it's not in the deep veins.
Mm-hmm.
That means an ultrasound test, and that is something that I have to get scheduled up.
When Doc started out, he used to come and see my folks. And he came on his bicycle. And my dad used to say when he saw him coming at noontime, "Here comes that young idiot." He didn't know what kind of a doctor he was.
This is Kenneth Whitehill. He's 93, and his family's like royalty around these parts. I took care of his father, Lucian, as he got old, and now I take care of Ken.
I can remember he and my wife used to argue, and he said, "If you don't like it, go to somebody else." But she thought she knew more than he did at the time. He was real young then. Yeah, he's, let's put it, matured. Of course, he still, I guess, rides his bicycle from Newport to Island Pond rather than take his electric car. So yeah, he's still a healthy boy. And we don't want him to retire. I think he needs to wait till I'm gone.
Why have I stayed so long? I feel such a sense of wonder every day. As a doctor, I have a front row seat on people's lives, and I love it here. I am deeply in love with the outdoors and this landscape. I can walk out my door and ski or bike in a beautiful place. My wife Ellie and I raised our 2 kids here. And I think there's a lot of ways in which rural areas are better places to live and raise a family. Not always, but a lot of ways. Everyone knows each other, and the lack of anonymity means that the social fabric is more genuine.
You know, that makes a difference if you really get to know the person or you get to know your own doctor. And he helped me out when my wife was real bad. She had strokes. And so I kind of listened to him and what he thought was best for her. And so I get to know him real well through that. No, I think Bob really knows what he's doing now.
All right, your blood pressure okay and all that jazz.
Yes, dear. It was 118 over 66.
Your blood pressure's always good, isn't it?
And I'm down to 141 pounds.
Wow. What are you trying to lose?
No,
Just being busy.
very busy, I told you.
I know your diet's pretty healthy. Is Gary keeping his weight down?
Actually, you'd be proud of him. He's really been working hard.
Is he keeping the beer down?
Actually, he's down to like 3 beers a night, sometimes 4. That's it.
Excellent.
Yeah.
So I won't schedule you back just yet, Jane. Okay, you can call.
Okay.
Because, well, let's see. When did you have your last physical?
August. I was here in August.
All right, I will schedule you back for August.
You'll still be here, right?
In August I will be, yes.
The most important thing is that you do your technical job very competently, but to do it in a way that you took care of people that you knew for long periods of time.
This is Dr. Thomas Mosley. Most people know him as Mike. He is a giant among doctors who opened a pediatric clinic here in the 80s. He practiced for almost 40 years. These days he's retired, and he's also one of my patients.
You know, that's what primary health care is about, having connections with those people. You know, on a given day, you might see a child of a lawyer or a teacher or a farmer or someone with no fixed description of employment. And, you know, in one way or another, they were all doing the best they could.
Any doctor worth their salt will tell you the same thing. But these days, it feels like the healthcare system has begun to disregard the most essential part of what it means to be a doctor. And things are shifting in ways that, frankly, I find to be in complete opposition to the work I'm here to do. This takes a few forms, but one of the most infuriating is the amount of time I waste on data entry instead of talking with my patients. I have to check a growing number of boxes in a growing number of poorly designed systems. The systems feel to me like they are designed to deliver data to managers and insurers rather than designed to help me do my job. When there are hundreds of items to check off a list, there is little hope of making time for the complexity and surprises of people's lives. Finally, though I could go on for much longer, the systems reflect a great deal of wishful thinking that if we harangue patients enough, they will change their lifestyles.
So much of the patient-doctor relationship has to do with intimacy, trust, knowledge of the things that aren't on the problem list, in which the lives that they really lead. And that's the part that is never going to show up in the medical record in a concrete description, and it's certainly not going to show in the productivity stats that the administrators are interested in. But I think that is the essence of caring for people.
These changes are harmful to the people I've spent the past 34 years taking care of. I'm disappointed that outpatient medical practice is going in this direction, and I don't want to participate in it anymore. At the end of the summer, I'm leaving the primary care practice. I'll still be working in the area, but only doing inpatient care at the hospital in Newport. I'll have more time to devote to our local trail network, to play music, maybe even do some work overseas or teach at the high school. None of that will be as important as the 34 years I spent as the doctor in Island Pond.
I think it's going to change things. I mean, he knows, just as I did, he knows people who will not, no matter what their medical problem is, will not leave the community to get care. So he's going to have to take care of it. And he does so with aplomb. So, yeah, I mean, it's going to be a huge loss. And a huge loss when this generation of primary care doctors disappears. And I have no idea who I'm going to go to for medical care.
After seeing patients all day at the office, I often end my day by getting in the car to make a house call. These are typically visits to patients who are old or dying and aren't able to come in to see me at the clinic. House calls are a special luxury when I am honored to meet people in their own space, even as they are departing it. It's been hard to tell people that I'm leaving. Every day, as I share the news with patients, I realize that I am letting them down. This job is critical. I know that I will never be good enough at it, and it certainly doesn't feel like I should ever finish. It's been a privilege to do this work, from catching infants to saying goodbye to old friends, or treating a middle-aged woman hit with multiple life-threatening issues at once, requiring endless tests, treatments, and multiple specialists, or a child laid low by a mystery illness, still unsolved, and yet the parents still seem to rely on me. Even a friend, taken down in less than a month by the Emperor of Maladies. There was nothing pleasant about that one. It was standing shoulder to shoulder with the family in the path of a tidal wave.
That story was put together by Dr. Bob Primo and freelance radio producer Anna Van Dyne. You can see photos of Dr. Primo with his patients on our website, vermontpublic.org. What were your reactions to that story? We're opening our phone lines now, and we'd love to hear from you this hour. You can call in at 800-639-2211. That story, as you heard, took place in Essex County in the Northeast Kingdom. Coming up, we'll head to Chittenden County, which faces its own constraints when it comes to primary care. This is Vermont Edition. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. As we just heard in a special audio documentary about Dr. Bob Primo, one of the only primary care providers in his region of the NEK, primary care is getting tougher to access in our region. Here to tell us more and offer a perspective from a different community is Jeff McKee. He's the Chief Executive Officer of Community Health Centers. They run 9 federally qualified health centers, or FQHCs, in Chittenden and southern Grand Isle counties. Jeff, welcome to Vermont Edition.
Oh, thanks for having me. It's a pleasure to be here.
So you were listening to that story about Dr. Bob Primo. I'd like us to start there. What stood out to you about that?
You know, Dr. Primo works in a very different part of the state, and some of the social issues that he contends with in the Northeast Kingdom are a little bit different than we have here in Chittenden County. But fundamentally, you could transplant that profile, that story, into any of our practices here in Chittenden County. And what stood out to me is that primary care physicians, providers of all types, are enormously committed people to their community and to the patients they serve, and often make exceptional personal sacrifices to continue that work.
Yeah.
It's very, very hard work, and we're deeply appreciative of the commitment people like Dr. Primo make.
Mm.
Yeah.
Well, if you are a primary care provider yourself, we would love to hear from you during this conversation. You can call in at 800-639-2211 or send us an email to vermontedition@vermontpublic.org. Jeff, do you have enough primary care providers to adequately staff your clinics, your centers?
You know, recruitment of primary care providers is increasingly difficult, and so right now we're down, I think, about 7 primary care providers in our practice. We're one of the larger practices in the state, but that means there's a lot of patients that we can't see. We could be doing a lot more if we could fill those positions. And recruitment of physicians in particular is even more hard. So we try to be about 50-50 between nurse practitioners and advanced practice providers to physicians. And right now we're about 2/3 of advanced practice providers. because primary care physicians are just really, really hard to find.
Is this a nationwide issue, or does this stem back to Vermont's ever-present housing crisis? Where's the shortage coming from?
Yeah, I know it is absolutely a national issue, and so every primary care provider or location across the country is kind of suffering from the same kind of, they're just not producing enough folks that are getting into that specialty.
Right. Oh, well, I would love to hear more about what it means to be a federally qualified health center, FQHC. That's an acronym that listeners, you might hear a lot in the rest of this hour. What does it mean to be an FQHC?
So a federally qualified health center is a little bit different than other types of primary care that people might experience. Not so much of the services that we deliver, but our mission that underlies that and who we serve. So about a third of all Vermonters get primary care from a federally qualified health center. And
a third, that's a lot.
A third, yeah. And the thing that ties us all together is a mission to serve all within our community. That's actually our mission, to improve the health of all within our communities. And for a federally qualified health center, that means something a little bit different than other kinds of healthcare providers you might go to. Every healthcare provider tries to provide amazing care to people who walk in their doors. And for a federally qualified health center, we're not only concerned about those that walk in our doors, but those who can't, who don't know how, who don't have the funds, who don't speak the language, who don't know how to navigate the systems to get that care, who might have other kinds of conditions that prevent them from seeking care. We care as much about those folks as the folks sitting in our lobby on any given day.
So you're trying to do all of that, and you are short primary care providers.
Yeah, that need is always higher than we've been able to meet across the 53 years of our history, right? We know that there's more work out there than we can get to. And at the same time, we know there are very significant challenges that we face ahead with respect to eligibility for Medicaid and what that might do to people's ability to pay for and get the care they need. So it's a tough time right now in primary care.
Yeah. So you run a federally qualified health center in Chittenden and Grand Isle counties. There's also a number of others, I think about a half dozen other FQHCs. Is that right?
There are 10 other FQHCs.
10 others, okay.
Yeah.
And those are spread all across the state.
Yeah, every part of the state is served by a federally qualified health center, mostly organized around counties or connected counties. Yeah.
Okay. So let's talk a little bit about what's going on with Medicaid. Lots up in the air right now. And for regular listeners of Vermont Edition, you've heard us over the past couple months try to keep up with some of these changes that are being announced at the federal level, some of which have been rolled out, some of which have not and are merely being debated. Right now, Congress is trying to find ways to cut the federal budget, and one of the proposals is to cut funding for Medicaid or roll back a Medicaid expansion. How exactly would that affect your organization, Jeff?
That's one of the challenges for us. We have so many patients who come in who are concerned about, am I going to lose my Medicaid? Am I going to lose my coverage? Can I keep coming here?
Yeah.
Well, we start with the last one first, which is, yes, you can still come here. All the federally qualified health centers have a mandate to continue to provide care regardless of ability to pay. So that separates us as well. So even as the amount of Medicaid coverage or people receiving Medicaid might go down, and the number of people who can't pay for their care might go up, that just means our demand goes up. And our funding will go down because we will do more people accessing our sliding scale, for example. So, but the reality is with the federal cuts, we know there's some large ones out there potentially looming. We don't know what that is. We don't know how it will be applied to the state, which manages the Medicaid. So everyone at the state level and in the legislature is trying to figure out and read tea leaves to say, what is this going to mean to us? How do we have to reserve funds from other places? In this year's budget, what can we afford to do? The state budget, yeah. And so that's really, really tough. So until the federal government decides what it's going to do, the state can't do what it needs to do, and all of us who kind of have a large piece of our care delivery system based on Medicaid, we don't know how that's going to affect us yet. So we just try to reassure our patients yes, we're still going to be here, and yes, you can get your care.
When will we know? Do you have any deadlines or dates looming?
I wish I had a crystal ball and could determine that. So we're hopeful. The state's trying to put its budget together now for the next fiscal year. Hopefully in the next month or so that'll be set up. Whether or not we'll have to revisit that sometime in the next year after the federal government decides on its budget, we're not sure.
Okay. So what does that mean for you and your days? Like when you wake up each morning, are you kind of checking your phone and your email to see what's happened next? Like how much of a surprise could this be?
There's all sorts of things right now that are kind of affecting the care that we provide that we're trying to keep on top of and make sure that we know how we need to adapt and adjust and make sure that we can continue to say that we're here for you always to our community. And so it for people like me who are administrators in the organization, we're obsessed with it. We try to protect our providers from it and so they can just focus on the patient in front of them and provide great care.
Right. But when you say we're here for you always, there's got to be a limit to that at some point. Is it we're here for you, but you might have to wait 6 months for an appointment? We're here for you, but you might not be able to access the type of specialty care that you need?
Yeah, it is all of those things. One of the other mandates for our federally qualified health center is that we always have to keep our front door open. We always have to accept new patients. And so sometimes that means that first appointment might be much further out, than anybody would like. It also means that we might not be able to do the follow-up care in the timeliness that we would like to be able to do. So we do have to figure out how do we balance the increasing demand with the capacity we have. Yeah.
Well, if you are a patient at a community health center, a federally qualified health center in our region, and have questions about how your care might be affected by some of these federal level changes that have been proposed, call in at 800-639-2211. Right now, we are speaking with Jeff McKee, the CEO of Community Health Centers, which works in Chittenden and Grand Isle counties. Jeff, we have to take a short break, but when we come back, I'd love to talk with you about some of the specific populations that your organization works with and how that might affect the care that you're able to provide. That's in just a minute on Vermont Edition. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. If you're just joining us, our guest today is Jeff McKee, the CEO of the Community Health Centers, a network of health centers in Chittenden and southern Grand Isle counties. Federally qualified health centers provide primary care, dental, treatment for substance use disorder, and other services to about a third of Vermont's population. Jeff, one of the ways in which your organization is unique is that you serve a large percentage of the state's homeless population. I read a statistic before today's show that said in 2023, federally qualified health centers all around the state served nearly 80% of the state's homeless individuals. What unique challenges come with that work?
Well, one of the challenges is obviously that it's hard to engage people that are unhoused. They may not be trying to expect someone who is unhoused to show up on time for a traditionally scheduled appointment in an office somewhere. It can be very, very challenging when they're just trying to get through a day and manage all the other stressors that come with being unhoused. So we're the state's only federally recognized healthcare for the homeless program, which means we get a little bit of grant funds from the federal government to do some specific pieces of work. And we are very grateful that we have that support, which has enabled us to provide various kinds of care management and case management. We actually have a mobile outreach van that goes to hotels, motels, encampments with medical providers and medical staff and offer care to folks. when we do that, we're never quite sure who we're gonna meet there. So we show up. They know our logo. They know our who we are as an organization, and they know they can trust us. So they access care, which is a really unique thing for us. But the cost of providing that care is not nearly covered by the grant funds we get from the federal government. So it's one of those really truly mission-aligned, health equity-focused kinds of initiatives that federally qualified health centers do that isn't fully reimbursed. And those are the things that, when we talked about the Medicaid funding challenges, become the most at risk because there's no revenue attached to those. And if you have a deficit, it's and a tight budget, those are the things that become most at risk.
And could you explain that a little bit more? I mean, we had these conversations recently on Vermont Edition with Owen Foster, the head of the Green Mountain Care Board, and Vermont's chief healthcare advocate, Mike Fisher. And they both talked about how hospitals and health centers are dealing with this issue of rising costs and inadequate revenue. And frankly, I still struggle to understand why exactly costs are rising and why there are such cost disparities between different health centers for similar procedures around the state. I know this is like kind of a Medicare-specific, Medicaid-specific issue for you all, but I wonder if you could tease that out a little bit for us who are outside the healthcare system.
Well, I'll not kind of drift into hospital costs and so forth, because even that overwhelms me. But with respect to the differences in costs between health centers or different kinds of primary care, the FQHC model, if you looked at it on a per visit basis, looks like it's more expensive because of all those other things that we do, the unfunded care, the always keeping the doors open, the accepting people regardless of ability to pay, and all the federal requirements that we have to meet to be an FQHC, data reporting and quality measures and so forth. So all those things add up to being a little bit more costly. But the biggest piece of that is the mission-driven health equity focus. And for me, I believe truly that health equity is a great investment. If we're not out there doing that outreach, if we're not keeping the doors open to people who can't pay, if we're not reaching into traditionally underserved populations within our community, the health disparities increase. People get sicker in those environments, and they wait to get their needs met and show up in the hospital, and they show up in the hospital sicker. And so one of the best investments that I think that we can continue to make in healthcare is to primary care, and all types of primary care, not just FQHCs, because it's not only the morally right thing to do, it's a good financial investment.
It's preventative.
Yeah.
Let's take a call here. We have Paul calling in from Richmond. Paul, you're on the air. What are your thoughts?
Hi. I'm a pediatrician in Richmond, and here in Chittenden County, it's even hard for people to find primary care. My concerns are that the governor and the state legislature are not taking this seriously enough. I think they need to do something to recruit primary care folks to work in rural areas, which means, making sure that they can make enough money to actually keep their offices open. But I think the state needs to do something about this, and I think they're ignoring it. Primary care, having a primary care doctor is one of the best ways to make sure that you're healthy. So people who don't have primary care are much more likely to end up in the hospital with problems.
Thank you, Paul, for calling in. Yes, a sentiment echoed by our guest, Jeff McKee with Community Health Centers. Jeff, do you think that there is something that the state could be doing, like Paul is suggesting, to help recruit primary care providers into Vermont?
That would be terrific if there were more kind of support for helping people, transition to what can be a much higher cost of living here, depending on where someone's moving from. So perhaps the state could. I do think the state is understanding the challenge of the federally qualified health centers, and I'm not sure that we've really fully addressed the broader need of better funding for primary care in non-FQHC settings, but I do believe that the legislature is really listening to us, and us being very transparent around the increasing losses and the vulnerability of several FQHCs, and across the state, the closure of practices has been real. So I think the state's listening. We could always do more. I'm not sure there's a proposal on the table that anyone's come forth with one specifically on the recruitment effort, but that's certainly something to consider. We'd definitely be supportive.
And as you mentioned earlier, we're entering this this key point in the legislative session where lawmakers and the Scott administration are trying to nail down what the state's budget is going to be for the coming fiscal year. What do you and other heads of FQHCs in Vermont, do you have a specific ask that you are hoping for, that you have put on the table for lawmakers that you are waiting to hear about? What exactly is on the table right now for you?
So what is on the table? Well, I'll back up just a little bit. So the Community Health Centers of Burlington, we've been in a process with the state trying to get what's called a change in scope. We've grown tremendously over our history. And when you have significant changes, there's a mechanism by which you can apply to the state to have your rate adjusted to reflect those changes and the new services that you've brought on. We've been in that process for over 2 years. And so we've had this need. And the need didn't happen just in the last few months.
Right, you were trying to get this change in scope for 2022,
I think
right?
we first applied at the very end of 2022.
Okay.
Yeah. So we think we're at the final stages of that initial change in scope process, which catches us up a little bit. But several of the other federally qualified health centers have had very significant changes in their operations, but haven't met the very specific criteria for a change in scope, and so they're further behind. But that's essentially it. All of the federally qualified health centers continue to evolve to meet the changing needs of the community. I think anybody looking at Chittenden County would recognize that across the last decade, the needs in our community of people who are underserved, the number of people who have emigrated to this part of the state, who don't speak English and who don't have other kinds of coverage has created kind of challenges with us keeping pace with providing that care. Not a complaint there. It just makes us a little bit different, and those costs go up. Mm-hmm. We really, truly are enjoy all of that work and lean into that work, but it's more expensive.
Right. Yes, I think I read that about 10% of your patients don't speak English or don't speak as a first language. And being in Chittenden and southern Grand Isle counties, you serve a lot of new Americans in the Burlington and Winooski areas specifically, many of whom have come to Vermont as refugees or asylum seekers. Do folks who have that refugee or asylum status, are they covered under Medicaid?
I think depending on the status that they have, some are covered or get coverage, and others are not. So not 100%.
Yeah.
Yeah.
Well, your fiscal year, it just ended recently at the end of April.
Yes.
And I know VT Digger reported a couple months ago that Community Health Centers was expecting to end the fiscal year with a $2 million operating deficit. I just want to put this out there to give listeners kind of a sense of what's at stake here. Is that what ended up shaking out at the end of April?
So we haven't closed the books yet on April, and so, but we expect that the loss is going to be somewhere in the neighborhood of about $2.4 million. Mm.
And what are some of the ways in which this type of loss shows up in your centers and for your patients?
So, when you have a loss, an operating loss month over month, it eats into your financial reserves. And so you have to be really careful. We're meeting all of our expenses. We haven't curtailed any services. We haven't laid anybody off related to that. We're still staying the course. But we have put off a lot of investments. We desperately need a new electronic medical record, one that talks to the hospital better than ours currently does. We have facilities in increasingly desperate need of repair. All of that gets put off because we don't have the financial reserves. We're nearing a point where the solvency of the organization, if not for the state changing its funding kind of commitment to us, we're just not sure how we're going to survive that. Having said that, I do think the state is listening, and we're expecting that the bills going through the legislature come through, that we're going to be back to a much more close to break even. And so it may not completely correct our operational losses, but it extends that length of time that we have before we kind of run out of money by a substantial amount. So that's what we needed.
Yeah. Well, you sound like you sound optimistic, but I can imagine that this must have been a harrowing couple of months, considering all the care that you provide to so many people.
Yeah, we serve about 35,000 people, 160,000 visits, and there's no way that we've taken all the cuts we can cut.
Yeah.
There's no way for us to cut more, quite literally, without losing more revenue, right? So the only thing left is to cut clinical services, and clinical services are how we earn our money. So again, I believe the state fully recognizes that, and they're going to do what they do. Everyone wants the federally qualified health centers to be successful. They need us to be successful. They understand it's primary care is a good upstream investment, and it saves money in the long run. So I think we're going to be okay. But it has been harrowing when you realize there's nothing more you can do except be really transparent and open and kind of plead with the state to pay attention.
Yeah. And Jeff, we have just a couple of minutes left here, and I know we've spent the majority of our conversation talking about some of the larger challenges facing federally qualified health centers, such as yours. I'm wondering if we could end with a moment of discussion about some of the work that you all are doing that means the most to you. I mean, as an administrator, I imagine you spend a lot of time in meetings and on Zoom and, in interviews like this one. But when you do have a chance to actually visit a health center and see this work in action, I don't know, is there a recent moment that stands out to you that reminds you like, oh, this is why I'm doing this really tough work?
Yeah. Well, there's a couple of things, but I think it comes back to a kind of a connection to where we started, which is Dr. Primo's work and his emphasis on relationships, that seeing the relationship between a provider and their patient, and in spite of all these other things that are frustrations with the work and challenges we have with financing, it still comes down to about how we care for each other, how we care for our community, how we care for our friends, our neighbors, other members of our community, and how deeply those relationships are felt at that individual provider level. And so, and also to kind of know that we are the place that our community trusts. If you're new to the community, if you don't know where else to turn, people walk into our center and we say, how can we help you? That's an amazing kind of role that all of our staff embrace, 350 or so staff lean into that. And to be able to work in an organization where our personal values of care for our community align with the work we get to do every day, that's what drives us all forward, I think.
Jeff McKee is the CEO of the Community Health Centers of Burlington. Jeff, thank you so much for your time today.
Oh, truly a pleasure to be here. Thank you.
And this interview, as I mentioned, is one in a series of conversations we've had over the past couple months on the challenges facing Vermont's healthcare system. You can find the rest of those interviews in Vermont Edition's podcast feed. We'll also link to a couple of them in the show notes for today's show. Today's Vermont Edition was directed by Mary Angish. Our managing producer is John Ahrens, and our producers are Andrea Lorian and Daniela Fierro. Anna Berg is our intern, and our call screener today was Kelly Delorier. Our theme music was composed by Myra Flynn. I'm Michaela Lafrac. Thank you so much for listening, and we'll catch up again soon.